All right, so I'll go
So
ahead
Dr.
with
Nishikant.
my talk now, which is on retinotomies and retinectomies. So these are very commonly used terms, and many a times we like interchange these terms. But if you go to technically, a retinotomy is basically cutting the retina, whereas retinectomy means you excising the retina. So retinotomy can be like a very small hole that we do a drainage retinotomy, or you can even have a huge cut for removing subretinal membrane to a 360-degree cut to relieve massive peripheral traction. A retinectomy basically means you are excising the retina and you can have excision of the fixed edge of the retinal flap, or if the retina is fibrotic, then you can go ahead and remove the whole fibrotic retina. So that is retinectomy. Now, both of these are used in extreme surgical maneuvers, and we have actually already seen quite a bit of them done in cases of PVR that we saw when presented by Sangeet and by Dr. Shubhendu. So let's come to first a drainage retinotomy. The first thing to remember is that when you're going to do a drainage retinotomy, it's better to remove all the periretinal membranes, and you should do it in an area where there is no traction. Otherwise, that hole or itself will open up and lead to a recurrent detachment. It should be done with the endodiathermy because it will, of course, give a hemostasis and the edges become white. So, you know, you can make out the hole once the retina is settled. Otherwise, you lose the identification of the hole created by you against the RPE. If there is a scleral buckle, then of course you should do it in an area supported by the buckle and not anterior to the scleral buckle. Otherwise, it's difficult to do the drainage through that. And again, you will lose it over the buckle. Now, sometimes you do a retinotomy to gain access to the subretinal space, and most of the times it is to remove a subretinal band or a membrane, like you can see in the video on the right. You can also do it to drain a subretinal hemorrhage or to remove a neovascular membrane, a subretinal foreign body, sometimes a PFCL, or a scar or an abscess, which gives us access to this particular subretinal space. Now, a subretinal blood can be, a massive hemorrhage, or the other one is on the right, which is by a Manish itself, where there's a large uh, subretinal hemorrhage, and you can go ahead and do a retinotomy, and you can go ahead and excise or remove the hemorrhage which is under this. So these are retinotomies that are done to gain access to the subretinal space, to remove blood, to remove subretinal fluid, to remove bands and scars, etc., that lie under the subretinal in the subretinal area. Now, the retinotomy and retinectomies, but most commonly we do it in PVR, like we have seen in earlier presentation itself. It is also done for retinal incarceration in traumatic or surgical wound, especially if you have a perforative wound, then it is better to do a retinotomy around the incarceration site to prevent PVR spreading from there. The PVR indications are roughly the same that you see. These are the various forms in which you can get PVR, but you need to do a retinotomy or retinectomy also if there is a fibrosis of the flap of the giant retinal tear, or there's a contraction, or if there's a proliferative vascular retinopathy in which the adhesion is so much that you can't separate the vascular membrane from the retina, so you have to excise the whole complex itself, and also in case of the inner wall of the congenital retinoschisis. Now, these are the typical situations in which you have to resort to a retinotomy or a retinectomy. You have a severe PVR or a contracted or a fibrotic retina, or the most commonly is when you are doing a fluid gas exchange, and when the exchange is about to be completed, you can see a subretinal escape of the air, and that shows that there is a retinal shortening or a contraction, and you need to go ahead and do an RR. Now, the trips and the tricks and the trips, tips and the tricks for this, sorry, is basically number one, remove all the membranes and the residual vitreous before you do that. Use stains liberally. You have to be as anterior as possible because the contracture inevitably results in less remaining retina than what you anticipate. So many times you cut it, and in the end, you see you have very little retina. So better to stay anterior. But having said that, don't undercut it just because you don't want to cut too much of retina. Otherwise, you end up leaving fibrotic retina, which again contracts and leads to failure of surgery. It's always better to have endodiathermy, and you can actually use the endodiathermy as a series of dots rather than creating a straight line, because the series of dots can actually cause you give you a better hemostasis, and you can actually do it on the major blood vessels only, so that you can prevent bleeding and you can prevent over cauterization in that area. Use PFCL, and if you're going to cut excess of retina all 360 degree, it is better to start with the PFCL to stabilize the posterior pole before you go ahead and do a full retinotomy 360 degree. Otherwise, the funnel might close in certain cases with hemorrhage, etc. You will find it difficult to open it again. You have to laser with care, and remember the edges of the viable retina should be sharp and should not be scrolled. Otherwise, you end up getting a redetachment. The common pitfalls are you can get choroidal bleeding if you're overcutting it or you're going close to the choroid. And the residual retina, which is necrotic beyond retinotomy, should of course be removed totally. Otherwise, there is a post-operative inflammation. It serves as a scaffold for proliferation and neovascularization, and that can cause an anterior loop traction, ciliary dysfunction, ciliary membranes, and can lead to a post-op hypotony, and you can lose the eye. And use silicone oil liberally, because these are large retinotomies and complex retinal detachments. So you have to do good justice by using a good amount of tamponade in these cases. Now, this is just to show how indicative case. Use a chandelier most of the times, because you're going to need a bimanual dissection many times, and it also gives you you're free to use manually bimanual. Do a good vitrectomy, and remember to do a good vitrectomy before you go ahead and rush to do your relaxing retinotomies or retinectomies, because a stiff retina gives you like a third hand, and it helps you in vitreous dissection. Remove as much as epiretinal membranes as possible. You have to do a very, very, very meticulous membrane removal, because otherwise post-operatively these membranes start contracting and cause a recurrence of PVR. It can cause retinal contraction, and your most of the retina might be settled, but your macula starts getting macular proliferations, and you might have to go in again just to remove that. Many people do ILM peeling also in posteriorly to prevent any post-op epiretinal membrane coming on the macula. You can trace out the subretinal bands, can do a retinotomy and remove the subretinal bands. You can increase the retinotomy to remove the subretinal bands. And once you have done removal with most of your membranes and the subretinal bands, then you can, like I said earlier, use PFCL to stabilize the retina. And after you put the PFCL, say up to the equator, you can reassess the situation. If the retina is still stiffer in spite of vitrectomy, you can go ahead and do endodiathermy in the edges, and like go ahead and do a retinectomy. In this case, we had extended the retinectomy literally 360 degrees because there was an anterior retinal contraction. Once you finish your retinectomy, be sure to excise all the retina which is anterior to the retinectomy, so that it doesn't lead to postoperative complications like I mentioned earlier. And it has to be meticulously removed. You have to spend a good extra time and do a good depression and remove all the retina which is in the periphery. And once all the membranes in the periphery are removed, then you can put in more PFCL, have a good retinal settlement, and then do a good laser. And like Manish said, it doesn't harm to you to give an extra layer of laser being given. And once you are done a good laser, trace out if there are other breaks around there, laser them also, so that you have had a good amount of retinopexy. And then you can finish it by exchanging it with silicone oil injection, which can be either a direct PFCL oil injection, which I prefer, or how Manish does it after fluid gas exchange. The complications, like I mentioned, can be hemorrhage from the choroid or the retina, so you have to have a good diathermy. A choroidal hemorrhage may result by impact of our instrument itself on the choroid. Many a times your instruments rub against the retina and the RPE, and you can find a damaged RPE which is there from subretinal instrumentation. So you have to be very careful when you're doing subretinal dissection. You can have an enlargement of retinotomy that may be due to excessive diathermy or due to incarceration of the retina. at the edge of the retinotomy when you're draining it. So you have to be very careful when you're doing FGE. And post-operatively, if you've done too much of retinectomy, you can get an extensive visual field defect. Large exposed RP can lead to PVR. You can get hypotony, like I said before, and neovascularizations can be there, causing retinal detachments. So just to conclude, performing a retinectomy, although it is simple in concept, it requires a lot of detail and a step-by-step way to ensure the best possible results. The retinotomy and retinectomies can improve the therapeutic effect of a complicated retinal detachment, especially in PVR cases. But there are too many complications with this maneuver, and therefore you have to be very careful while performing these. Thank you very much. Thank you to AIOS for allowing me to conduct this IC or choosing it. And I thank AIOC on behalf of all the participants.